Good morning to all. Myself, Dr. Deepak Jaybhaye. I'm presenting the topic Evidence of Oromotor Intervention Programs. My moderator is Dr. Saikat sir. These are the today's specific learning objectives of the presentation. Introduction, evidences, various RCTs, Cochrane analysis, and take-home message. Recently, the survival of preterm infants have increased, and the delay in transition from the gauge feeding to the oral feeding due to immature oral motor function prolongs the hospital stay. To mitigate this problem, the oromotor stimulation can help. The PIOMI is a structured 8-step therapy of oromotor stimulation lasting only for 5 minutes, including 2 minutes of non-nutritive sucking, and is designed to replicate in utero sensory motor experiences. It facilitates the feeding and coordination of sucking, swallowing, and breathing. Multiple RCTs have shown the PIOMI to improve the oral feeding outcomes and also improve the readiness to feed, oral motor function, breastfeeding, and faster transition to full oral feeding. The RCTs have shown PIOMI positive effect on the NNS score, behavioral state, and higher scores on Infinite and sustained at 3 and 6 months after discharge. The first RCT is oromotor stimulation for transition from the gauze to full oral feeding in a preterm neonates. In this, they have included the neonates from 28 to 34 weeks, and in the intervention arm, they have given the either oromotor stimulation along with the routine care, and in control arm only routine care have given, and the result shows there is the time to reach partial and full spoon feeding were significantly lesser in an intervention arm. Then another study, pre-feeding oromotor stimulation program for improving oromotor function in preterm infants. They have included around 28 to 32 weeks of gestation age preterms, and in intervention arm, pre-feed oromotor stimulation using PIOMI, that is structured stimulation has given, and in control arm they have given unstructured stimulation. Then outcome assessed by using the NOMAS scale, that is neonatal oromotor assessment scale, after 7 days of intervention and time to full independent Vati spoon feed in preterm infants. And they have seen the result shows that NOMA scale was significantly higher in case of PIOMI group, and transition time to reach the full feed is also lower in case of PIOMI group. Then another study, a randomized control trial to compare the effect of PIOMI and routine oromotor stimulation in improving readiness for oral feeding in preterm neonates. In this, they have included preterm of 29 to 33 completed weeks of corrected gestation age, and in intervention, they have given the PIOMI, and in control, the unstructured oromotor stimulation, and they have observed the POFRAS score, that is premature oral feeding readiness assessment scale. A result shows that mean chronological age and time to oral feeding readiness were significantly lower in case of PIOMI group, and the transition time to full oral feed was 2 days lower in PIOMI group, and also the duration of hospitalization is lower in PIOMI group. Then another RCT, pre-feeding premature infant oromotor intervention for transition from gauze feeding to oral feeding. They have included around 32 preterms of 28 to 32 completed weeks gestation, and they have given the PIOMI for 5 minutes twice a day along with routine care once they reach the full feed of at least 150 ml per kg per day by gauge feeding method, and in control group they have given the routine care, and result shows that transition from gauge feeding to full feed was significantly attained earlier in intervention group than the control group. Then another RCT is effect of premature infant oromotor intervention combined with music therapy on feeding progression of a premature infant. In this, they have included the preterm with gestation age of 26 to 30 weeks. And in intervention, they have given the PYOMI along with the music therapy. And in control arm, only PYOMI is given. And they have assessed for weight gain, feeding progression, preterm oral feeding readiness skill, and milk volume and length of hospitalization. In intervention arm, reached independent oral feeding earlier and length of hospital stay was shorter, and the POFRA score was higher in the intention arm, and there is no difference seen in case of weight gain in between two groups. Then another RCT is effect of follow-up home-based oromotor stimulation on breastfeeding performance in preterm low birth weight infants. They have included preterm infants less than 34 weeks of gestation, and they have given oromotor stimulation was given for 21 days as a home-based program, and in control arm they have a routine care. Result shows that OMS improved the sucking frequency, latch score, and it hastened the transition from spoon feeding to breastfeeding as compared to control group. And there is no difference on the weight gain in two groups. And the early premature infant oral motor intervention improved the oral feeding and prognosis by promoting the neurodevelopment. In this study, they have included in preterm infants of 26 to 36 weeks of gestational age. And in intervention, they have given PYOMI for 15 to 30 minutes before feeding once a day for 14 days. And in control arm, they have given routine care. And they have seen that result shows that in intervention group, there is a higher POFRA score and higher feeding efficiency and shorter transition time for assisted oral feeding to independent oral feeding. And the percentage of infant with normal score on the Infanip scale were higher in the intervention group at 3 and 6 months of age, and abnormal ratio was lower in the intervention group at 6 months of age. Then another RCT is comparison of effect of two methods of sucking on pacifier and mother's finger on feeding or oral feeding behavior in preterm infants. They have included around 150 preterm infants with gestational age of 31 to 33 weeks. They have divided these infants in three groups. Group A, which included non-nutritive sucking on mother's finger, group A, and on pacifier, group B. Infant with group A and B were stimulated with mother's finger or pacifier 3 times a day for 5 minutes before gavage feeding for 10 days. And in control arm, they have given routine care. The result shows that mean score of breastfeeding behavioral, mean rooting score, and mean sucking score in group A, B, C shows significant difference. But other scales had no significant difference between the three groups. And there is no significant difference shown between two groups A and B in terms of rooting, sucking, and total score of breastfeeding behavior and time of achieving independent oral feeding. Then next RCT is effect of swallowing exercises and non-nutritive sucking exercises on oral feeding readiness in preterm infants. They have included infants with 27 to 30 weeks of gestation and divided into three groups. Group 1 has given an NNS twice a day, and group 2 second has given 15 minutes of NNS along with 15 minutes of swallowing exercises daily for 10 days during two subsequent weeks. And in group 3, they have given the routine care. And there was a result shows that there is no significant difference between the mean post-menstrual age at the start of oral feeding, full oral feeding, and discharge time, and the mean transition time. And compared to the control group, more infants in the group 2 were discharged without tube feeding. Then next study is a clinical effect of oromotor intervention combined with non-nutritive sucking on oral feeding in preterm infants with dysphagia. They have included preterm infants of 27 to 30 weeks of gestation, and in intervention arm they have given oral motor intervention combined with NNS, and in control arm only NNS is given. Uh, the result shows that POFRA scale of two groups significantly increased. Profile score was increased after 14 days in both the groups, and was significantly higher in the intervention group. And after 14 days of intervention, the intervention groups milk sucking rate and amount were significantly higher. Then another study, enhancing breastfeeding establishment in preterm infants. 33 preterm infants are included, of gestation is less than 34 weeks. In intervention arm, they are given NNS on an empty breast, and once a day for 15 minutes. And in control arm, they are given NNS on pacifier. The outcome study was exclusive breastfeeding acquisition. An infant who received the greater than or equal to 50% of direct breastfeed at a hospital discharge. The significant greater number of infants with the NNS empty group acquired exclusive breastfeed at hospital discharge as compared with those of NNS specifier group. Then another RCT, effect of premature infant oral motor intervention on sucking capacity in preterm infants in Turkey. Included the infants with 26 to 29 weeks of gestation. In intervention, they have given PYOMI for 5 minutes per day for 14 consecutive days. And in control arm, they have given routine care. The result shows that significant percentage increase in case in sucking power, and continuous sucking before releasing the bottle, and sucking time and sucking amount in experimental group, and also shows the higher increase in weight and head circumference in case of experimental group. Then the another study, efficacy of oral motor intervention on feeding outcomes in newborn with hypoxic ischemic encephalopathy who received therapeutic hypothermia. In this, they have included the infants who underwent the therapeutic hypothermia with the diagnosis of HIE, and they have given the PYOMI uh, as a oromotor intervention, and in control of only routine care is given. This result shows the time to full feed, full oral feed was significantly shorter in case of all three stages of HIE, and while time to per oral feed first, and per oral half, and per oral full feeding and at discharge were shortened in case of only stage 3 HIE. The Cochrane analysis also shows that oral stimulation compared with the standard care, that uh, time to to achieve full feed was decreased, and also the total hospital stay was decreased in case of oromotor stimulation as compared to the routine care. And they have also compared the oral stimulation along with non-oral intervention, and the result shows the same result, that time to achieve oral feed was decreased, and time total hospital stay in days was also reduced. The take-home message is PYOMI promoted neuromotor coordination by improving the neurodevelopment, thereby improving the oral feeding ability and prognosis of preterm infant. The oral stimulation program improves the oral motor skills and growth velocity in 28 to 32 weeks of preterm infants. Then oromotor stimulation along with NNS can significantly improve the oral motor ability of premature newborns, improve the process of oral feeding and its outcome. And the PYOMI has significant positive effect on anthropometric sucking capacity readiness to initiate the bottle and breastfeeding. PYOMI along with music therapy can improve the feeding progression in premature infants. Thank you.